I am happy to be here with my NICU colleagues. It sounds to me like most of you are NICU folks, not just nurses, but other practitioners also. So I'm really happy to be talking to a transdisciplinary group of people. A lot of the slides I have a little bit of a nursing focus, but we certainly are teaching EBP to folks across all disciplines these days, both in the academic side and in our clinical work that we're doing. So the transdisciplinary audience is fantastic. So I'm just going to jump right in here, tell you a little bit about where I'm from. The Center for Transdisciplinary Evidence-Based Practice, as Austin said, is at The Ohio State University, based in the College of Nursing. We recently have been endowed by the Helene Fold Trust out of New York with a $6.5 million endowment to our center, and we are going to be launching the Helene Fold National Trust Center for Evidence-Based Practice in Nursing and Healthcare this fall. So I wanted to let folks know that so that you will have a sense of what we're doing here at our location in Ohio State is really totally dedicated to bringing evidence-based practice to the world, both teaching it and consulting with organizations and really trying to help people not only understand what EBP is, but how do you really make it a reality in your organization, no matter where you are on the globe. And so that's the fabulous work I get to do every day. And so let me just jump right in here and get started, because I want to get through as many of my slides as I can, if I can make my slides move. Here we go. Okay, so what I want to start out by talking about is really what is the background for, why evidence-based practice, why does it matter? And the first place I like to start is kind of having everybody think about where are we at in healthcare today, and is there a possibility we could do better? And so here's where we're at. Currently, the latest literature on unintended patient deaths caused within the healthcare environment is there are 400,000 unintended patient deaths per year in the U.S. healthcare system. And that is an outrageously high number. And we are also, what's not on this slide, is the latest literature, which says we are now considered the third leading cause of death. So there's cancer, there's cardiac illness, and then there's being admitted to a hospital in terms of what are your greatest risk factors for death. And so that's pretty embarrassing and pretty devastating, and we certainly can do better. So beyond the deaths that are caused in the healthcare system, there's another many millions more injuries that are caused. And when we think about why is all this badness happening in hospitals, very little of the bad things that happen in hospitals are intentional. 95% of the errors involve truly competent people trying to do the right thing, and they fail because of design failures in our systems, in our communication, and the ongoing resilient presence of variation in care. And as a result, patients get a lot of the wrong things happen to them, and they only get about 55% of what they actually should be getting. So for those of you who are football fans, when we think about 400,000 people, at Ohio State, we're kind of into football, and this is a picture of our football stadium, which holds about a little over 100,000 people. So if you filled that stadium 4 times, and everybody in the stadium was met their demise 4 times, that's 400,000 people. So that gives you a little bit of scale of what's happening in healthcare these days and how we must do better. And variation is really the key. And variation comes out of preference, tradition, anecdote, the way we've always done it, and variation is the enemy of quality. And the unexplained variation in practice and widespread problems in quality and safety are overuse, underuse, and misuse of healthcare services, not problems caused by a few incompetent people. It is the failure of an entire delivery system. And we do have to really look at how are we going to fix healthcare with a completely different way of looking at how do we practice. So whatever it's going to be a major sea change. And that's what we have to be looking at, these small incremental little maybe we'll fix this, and maybe we'll do that, and maybe we'll tweak this, and that's not going to do it. And so I briefly want to talk about what is this costing. This is an estimate from 2008 that poor quality is costing the United States about $720 billion a year, and that's an old estimate. So it is extraordinarily expensive to be delivering the poor kind of care, the poor quality care that's going on. And a tremendous amount of money could be saved and reinvested in different ways if we were to be actually providing evidence-based care. So what is the point of evidence-based care? What evidence-based care is, it basically care decisions and practice are based on science rather than whatever else you might want to say is currently driving practice, which is tradition, provider preference, whatever it might be. So in 2003, the IOM called for 90% of healthcare decisions to be evidence-based by 2020. And that's only now 3 years away. And in 2003, that seemed like a pretty reasonable goal. In 2017, we are currently at about 30% of healthcare decisions are evidence-based. So chances of us reaching the 90% mark by 2020 are pretty not realistic. So we unfortunately are not going to meet that goal. So what do we know about evidence-based care? What we know is evidence-based interventions, evidence-based care, evidence-based decision-making have absolutely been shown to drive better outcomes, patient outcomes, organizational outcomes. So when we do evidence-based care, things are ultimately better for patients and the organization. They are the key to high reliability organizations, and high reliability organizations are what hospitals and airplanes should be. In other words, what are those industries that should never make mistakes? Flying an airplane and taking care of patients should be a highly reliable process. And a culture and a system for an evidence-based approach are definitely key structures for being highly reliable. Patient safety, highly correlated, and this is a systematic review that was done in 2010 where they looked at patient safety. The essential components include evidence-based practice. So it's just known that an evidence-based approach to care, evidence-based decision-making, evidence-based practice, not just 3 EBP projects a year. That's not what I'm talking about. I'm talking about an evidence-based approach to care all the time. When we decide what we're going to do from one moment to the next, we have the process in place where we have taken the due diligence to make sure that what we do is evidence-based over and over and over again. So it's not just something you do on top of everything else, which is why people say we don't have time for it, because we don't have time to do anything on top of everything else. A truly evolved evidence-based environment is where an evidence-based approach and the inclusion of evidence in our ongoing decision-making is happening all the time. So where does evidence come from? Evidence is the looking to what knowledge do we have, what external resources do we have to tap into, and how do we keep our own knowledge current and based in science. And so I love this quote, knowledge keeps no better than fish. In other words, if it's not, if it's not kept up to date and it's not refreshed on a regular basis, it really starts to stink. So here's what happens over time to knowledge when you do nothing. If you don't read anything, if you don't go to any conferences, if you don't participate in the current literature, here's how current you stay in knowledge. And as you can see, it's a pretty steep slope in the wrong direction. So what we know is everybody has to stay engaged in the knowledge game in order for practice to stay current. So therefore, that kind of leads us to what is evidence-based practice. So the first thing I want to say about evidence-based practice is it's not evidence-only practice. What we hear from a lot of people in the early days of evidence-based practice was a real rejection of evidence-based practice because people were like, it's cookbook medicine, it's cookbook nursing, it's cookbook fill in the blank. You don't value what I bring. My experience, is devalued by evidence-based practice. And anybody who says that to you is somebody who doesn't know what the definition of evidence-based practice is, because evidence-based practice requires not just a consideration of the current best evidence, but it requires your own expertise and your critical thinking as a clinician to process that evidence and utilize that evidence in your decision making with patient preferences considered. So it's not evidence-only practice, and so that kind of a response to it is an uneducated response to it. So it's utilizing the current best evidence, clinical expertise, and patient preferences and values in making decisions about how you're going to take care of a patient. So you'll all enjoy this picture. This is a picture from an OB textbook from the 1930s, and that is the exact actual writing that was under the picture, resuscitation of an asphyxiated infant. So I'm sure you will all guarantee me this is not how we currently take care of an asphyxiated infant anymore. So the point of me including this picture is we've always been doing evidence-based practice. Practice is evolving all the time. And so the idea that that people really resist it and don't believe it's important or don't believe we can do it, or we do it. It's just the availability of the knowledge and the science and the literature has changed. Literature and science are not only in textbooks anymore. They're in the databases. They're much more available, and they are new knowledge is coming out so much more rapidly now that we have to find and we have to learn how to keep current in the current environment. And if the knowledge is there, we as the professionals are responsible to know what it is. And so I love to put this picture up because it's like, well, why is this picture in a textbook in the 1930s? I mean, why is this cutting edge? Because it certainly doesn't look cutting edge to us anymore. But the gloves are, absolutely cutting edge, as is the lab coat. And quite frankly, it may have been that this is when people were first discovering that gravity could help, clear an airway. So just keep in mind that this is not something that's revolutionary and new. We have always had evidence-based practice in our lives. It's just that how do you build organizations and systems where evidence-based thinking and decision-making are keeping current with the knowledge that's out there. So the fully evolved evidence-based practice clinician is somebody who is evidence-based in their practice all the time. They're not, we're not in these environments where you go to a unit and somebody says, well, here's our quality projects over here, and here's our EBP project for the year over there. That's a nice start. That means, we're starting to integrate this kind of thinking. But truly, when you are an evidence-based organization, it's not like this other thing you're doing. So that's what we want to move organizations towards. So there's a lot of models out there of EBP, and they all basically include, these are the steps of evidence-based practice, right? So back probably about 10 years ago, most of the models started with teaching people how to write a PICO question, which is step number 1. And so you ask the PICO question, that's how you get into the databases to do your searching, because they're searchable questions. Then you find the literature. We teach people how to get back into reading the literature and rapidly appraising the literature rather than spending 2, 3, 4 months reading a research article and tearing them apart. We want you to be able to rapidly appraise the literature. And it's looking at the body of evidence that's out there about a question, not just one article, not just one seminar you attended. It's the body of evidence. And then how do you take that body of evidence, integrate it into practice, see how it's working in your practice in small tests of change, and then measure your outcomes, and then integrate the practice into day-to-day practice, and then disseminate your outcomes. How did it work out? Tell other people, present, and that sort of thing. So steps 1 through 6 have been around for a long time, but what we have found in the last years of trying to get people to start using this process, when we would go out and work in organizations and we would say to people, all right, Let's work on the things that are driving you crazy. What do you want to know the answer to? What are those things that you wonder, why do we do it this way? Or we've been doing it this way the last 10 years. I wonder if this is the best way. We would talk to a room full of 100 people and say, so what are your questions? And people would look at us like, well, we don't really have any questions because we have a policy, we have a checklist, we have somebody who already took care of that for us. So we really aren't supposed to ask any questions around here. I've actually had people say to me live and in person, we're really not supposed to wonder around here. And when you have an environment where wonder and inquiry and questioning practice are not the normal, expected, required, celebrated, recognized, and wonderful way that we do things, you don't have clinical inquiry. And if nobody's able or comfortable asking questions, then you never have a question. And if you never have a question, you never go looking for an answer. And you never go looking for how should we do this differently? And are we current? And is this the best? And should we be changing this? So we added step 0 because this is what we found was missing in most organizations, and that's why EBP never got going, is because the culture of curiosity, the culture of pushing back, the culture of everybody can ask a question anytime and it's safe, that's what was missing. And it isn't until you build that kind of environment and culture and safety that EBP can ever even get started, let alone survive, let alone thrive. And so that's why that step 0 had to be added, because when we go work with an organization, that's the first thing we talk about. And that means we're talking to leadership, because who sets the culture, who creates the environment, who sets the tone, who makes it safe? Leadership. And that's not just the chief nurse or the chief executive officer. That is high-level leadership, that's unit-based leadership, and that's clinical leadership. So your clin specs or your directors of your departments and also your C-suite folks. All of those people need to be aligned in a way that clinical inquiry is supported so that clinicians at that point of care, whether it's at the bedside or at the chair side in an ambulatory setting or in home care or wherever, so they are safe and supported in wondering and questioning everything all day long and having ways to bring that question forward and find the answer. So those are the steps of EBP. I don't know, different hospitals use different models of EBP. They're all wonderful. Iowa, Hopkins, you name it. I love them all. It's just that's the reason. That's the only way that the next steps can work is if you really work on step 0. And oftentimes step 0 is the toughest, okay? This is just another picture of the steps, but what can just a kind of more of a story about what can happen. So you ask your question in your clinical inquiry, you search for your answer, you put together your body of evidence, and these 2 pink and purple boxes here, once you find the body of evidence, then you integrate it into practice. But sometimes there isn't a body of evidence out there. It's not there. The answer isn't there. And when there is not a convincing, compelling body of evidence out there, then tag your it. Now you've got something that needs to go onto your research agenda. So this is where the split occurs between research and EBP. Any question that comes up should go through the EBP funnel first to see if the answer is already known out there. And if the answer is known, we don't need to do more research. We need to take the literature, we need to take the evidence that exists and put it into practice in our environment. If the answer is not known, then you can't change your question and run away. You have to connect with whoever your research colleagues are or affiliates are, but now it's a research study. And so all questions go through the EBP funnel first. And what comes out the bottom of the funnel is, here's what the best practice is. It's well known. We are either doing it or not. And if we're not, we need to. And if what comes out the bottom of the funnel is the answer isn't out there, then that's research. And the most important, well, not the most, but one of the important things about that is that will help us do research on the things that we still need to find the answer to, and that will help us stop doing research on the things we already know the answer to. There are certain things in healthcare that we know what we should be doing. And I go around the country and people are still doing another research project on CAUTI, another research project on CAUTI. I mean, after a while I'm like, please, no more. We know exactly what the best practice is for CAUTI. Let's move on to some other things that we don't know the answer to. So having an evidence-based approach where we look to the literature to say what do we know the answer to and what do we not know the answer to, not only will that drive your best practice agenda, that will drive your research agenda also. Okay, so that's just a little bit different picture of the steps here. So what's the point? Why should we even bother doing evidence-based practice? Why should we change our culture? Why should we go there? Well, here's the reason. There's a couple reasons. The first and most important reason is patients do better. Patients' outcomes turn out to be about 28% improvement in patient outcomes when patients get the evidence-based care they're supposed to be getting. Almost 30% improvement in outcomes. Now, if anybody can tell me what you can do in a healthcare environment to get you a 30% improvement in patient outcomes, other than this, I'd like to hear it. But I've never heard of anything else that will get this kind of improvement for you. So if your family member were the person in the bed or in the chair, wouldn't you want the people taking care of your family member to be receiving evidence-based care from evidence-based clinicians and getting a 30% improvement in their outcomes? You bet you would. And so if that's what we want for our loved ones, and that's what we know we can achieve by doing practice the way we know is best practice, then that is our responsibility to do that. So the first reason we need to do this is because patients have far better outcomes when they get evidence-based care. The second reason is it's our job. If you're a nurse, speech therapist, physical therapist, respiratory therapist, OT, physician, when you say, I am in this professional role and this is what I do for my life, and you can trust me to take care of your family member because you can believe me that I'm an expert of this, because that's what all of our code of ethics say we are. When you read the code of ethics in nursing and any of those other disciplines I just listed for you, because I've looked them all up, what those code of ethics say is we're the experts in our discipline and you can trust us. And when you put your family member in our care, we're going to do the right thing because we're current, we provide best practice, and we have an ethical obligation to you to do that. That's what it says. And so not only is an evidence-based best practice approach to care good for patients, but it is your job. And so that's what you come to work to do. The next reason is the answers are out there. There is so much knowledge out there, and the knowledge is sitting out on shelves, and the questions are sitting at the bedside, and people aren't connecting what's known to be best to the care we're delivering. And so it is our responsibility to figure out and to learn and to know what are those skills, what are those competencies that help you be able to, maybe you don't go find every answer all by yourself as an individual clinician, but the organization needs to be set up so that there are mentors and knowledge brokers in the organization that every staff member can reach out to and say, I'm wondering about X, Y, and Z. I want to find out what the right answer is. And those knowledge brokers and those EBP experts need to be able to facilitate those clinicians being able to find those answers, because I'll tell you what, in all the work I do, and I'm out on the road talking about 100 people a week working on EBP projects in different organizations, and out of 100 projects a week, I would tell you, this is anecdotal, probably 80% of the projects that people work on every week, they find the answer in the literature. Less than 20% end up being unanswered. It's not known. We have to still do more research. So the answers are out there. We just need to find the will and the way to go get the answers. So it's great for patients. It's your job. And the answers are known. So that's why we have to do this. So in spite of the fact that all those things I just said, it's the right thing to do. It's good for patients. It's your job. And we do have the answers available to us. What do we do? Are we doing evidence-based practice? The answer is about 70% of the time, most people are not taking an evidence-based approach to care. About 30% of clinicians are evidence-based in their practice. The other 70% are not. And that's an improvement in the last couple of years. So a little bit of improvement, not a lot. So what do we do instead? Tradition-based care. Now, I don't have a lot of time to go through a whole bunch of these, but there are things that clinicians do all the time that if you ask them, why do you do that, they can't tell you. And a lot of the time it's because there is no reason to be doing it. It's just that what they've always done, and they don't even know why they're doing it. Like changing IV sites every day, or every 72 hours, or every 96, or every whatever. Everywhere I go, they got a different number for how often they change IV sites. And it's like, why? We don't know. Because that's the policy. And quite frankly, the time to change an IV is when it's clinically indicated. So there's lots of things. Waking stable patients at night to do vital signs on patients who are sleeping and stable. Delivering albuterol in nebulizers rather than MDIs. I mean, I could go on and on and on. So people are just out there they're just robotically doing what they've always done, and they can't even explain why they're doing what they're doing. So that's tradition-based care. The other bucket of stuff that people fall into is provider-centric care, which is things we do that are really about provider schedules rather than patients. So here's some examples of that. Again, you can read them, but there's a lot of things we do that really aren't about patients and being patient-centric. They're about what works out for the staff. And so until we're evidence-based and patient-centric, we're not where we need to be. So I'm going to push ahead a little bit because I don't want to get too hung up in, I want to get on to some other solutions here. So I want to talk a little bit about what do we know about the history of EBP. Particularly in the evidence-based medicine has been around longer than some of the other disciplines, but particularly in nursing, in 2005, we were pretty much not on the map at all relative to evidence-based practice. Most nurses didn't value it, didn't do it, weren't interested in it, didn't think it was important. And in 2012, we did a study out of our center to kind of say, is that still the case? And we found that things had changed. There was much more value for EBP. People wanted to do evidence-based practice. They didn't know exactly how to do it. They didn't have enough education. They didn't have good mentors. They didn't have help. But their value for it had changed. The other thing that we found in 2012 was there was a new barrier that was emerging, which was manager and leader resistance. The other barrier we've heard for decades. We don't have time. The organization is resistant. We don't have the knowledge. We don't have access to the literature. But in 2012, we heard this new thing, that there was manager and leader resistance. This is a very interesting finding. The other thing we found out was that more highly educated nurses, because this was a study about nurses, were more clear about EBP, and the more years in practice, the less nurses were interested in learning about it or doing it. So the more senior, not necessarily in years of age, but the longer people had been in practice, the less interest they had in participating in an evidence-based approach. So things, have been changing, and so it's contextual. Where we're at with EBP is contextual, and it has a lot to do with the organization. So then we did another study to dig down about that leadership problem that we had identified. So we did a chief nurse study in 2013. Where are our nursing leaders on EBP? And here's what we heard from a national study of nursing leaders. Here's what we heard. They told us EBP is super, super important for them as chief nurses and for the organization to do. Okay? Very interesting. I'm very encouraged when I see this slide. The next question is, what are your priorities as the chief nurse? Look at where EBP falls. Almost off the map. And quality and safety were chief nurses' top priorities. Okay, I love quality and safety. And what we heard when we had a forum at the AONE conference with chief nurses and we presented this data, here's what we heard them say. We think EBP is really important, and as soon as we get quality and safety fixed, we're going to really take off on this EBP thing. What they totally disconnected on was you will never get quality and safety unless you do EBP. Because trying to do quality and safety the way you've always been trying to do quality and safety isn't working. Evidence-based approach to care is what will get you there. And that was a very, very telling disconnect in the chief nurses. And the other thing we found out is they don't spend any money on it, and their own personal implementation of an evidence-based approach in their own practice was very low, and they felt that their organizations were pretty much not really ready for EBP. We also heard from them that they're not meeting, about a third of the hospitals are not meeting benchmarks, about a third were just at benchmark, and about a third were ahead. They don't think their organizations are ready. They don't have EBP mentors. They don't spend any money on it, and they don't see how they can fit it in, and they don't have the tools to make it real in their organization. So we are doing a lot of work with creating toolkits for leaders. The other study I want to quickly tell you about, this is a study we did with nurse educators and professional development nurses about 2 years ago. We just published these findings. Very different findings. So that was the chief nurses disconnected from the EBP quality safety connection. Here's what we found out about educators and professional development folks. They rated themselves very, very low on these basic competencies of EBP, how to formulate a PICO question, how to search, how to do very basic EBP stuff. These are your educators, okay? These are nurse educators. But on their beliefs, look at where they were super high on their beliefs. They believe they're clear about the steps. They believe they're delivering it. They believe they can implement EBP. These are the same people who on the last slide said, I don't know how to do it, but I believe highly in it, and I'm very confident I'm doing it. And they also talked about what they are implementing. So they are implementing EBP, but they also told us they don't know how to do it. So this is a very scary disconnect, which is people are out there teaching it and doing it, but when you ask them what are your skills, they don't have the skills. So we have very different buckets of ways to make improvements in our clinical picture. Some is education, some is resources, and some is, a lot of work we have to still do with leadership. So how do we move towards an EBP culture? So people are like, it's overwhelming, I don't think we can ever do it. Well, here's the thing. You can either take an optimistic or pessimistic look at this and say half full, half empty, and the opportunist says, I'm going to just drink the glass of water. So that's the attitude I take, is there are so many opportunities to make this a reality in your organization, and whining about it and worrying about it and thinking about how difficult it is isn't going to get you anywhere. So here's the basic things that we know you have to have in place to begin to create an EBP culture where EBP is even possible. It has to be in your mission. It has to be clearly stated somewhere that this is what we do here and that we're committed to it. And so when people behave in a way that isn't about best practice, you can hold them to the mission. You can say to them, how does what you or we are doing right here, right now, align with the mission of this organization? So it's got to be, from a very high level, clearly stated that we are committed to an evidence-based, best practice, science-driven approach to care. The next thing is, I talked about it already, I'm not going to beat this dead horse, is this spirit of inquiry. Inquiry, safety and inquiry has got to be in the culture, all right, for everybody. Everybody is able to ask questions. The next thing is these EBP mentors, people within the organization who are EBP experts, who know what those steps are, who know how to go search, who know how to look at the literature, who can align themselves with those clinicians at the point of care and help them find the answers to their questions. Because not everybody in the whole place is going to be an EBP expert, but everybody in the place needs to have inquiry and needs to participate in the process. But you've got to have these experts that walk amongst the clinicians. You have to have administrative support, role modeling, and people in leadership roles who are walking the talk, pushing through barriers, and helping to make EBP a reality. Because one EBP champion walking around in one hospital is not going to ever be able to change the culture. So leadership has got to get involved, be evidence-based in their own practice, and be supportive and present and publicly navigate the barriers. You also need stuff. You need resources. People do need access to the internet so they can look stuff up. People need time to read the literature. People need access to librarians. So there are some resources that you must have in place. Most places do pretty good with buying stuff. What they don't do very well with is doing something with the stuff. So some places have more of a struggle with infrastructure and resources, but that is not what we usually run into. And the last part of the culture that has to be built is an opportunity for recognition, for small gains, for evidence-based practice being recognized and the wins we get and the outcomes that we achieve, and that there has to be ways that it's receiving public recognition. Okay? So some of the things you need to be thinking about is what's the organization that you're working in looking like? So there are lots of tools out there, whether you're an academic organization or a clinical organization, same thing. There are surveys and tools available for you to assess the culture. And they're very valid and reliable tools. They've been around, they're well tested, and basically they will give you a real picture of how ready are we? How ready is this culture, and where are we weak, and where are we strong, and what can we leverage, and what do we need to fix? So an organizational assessment is critical. This is the ARC model, which is an organizational EBP model, which we use all the time. And basically it starts on the left-hand side with that organizational assessment. And just like I said, we gather that data, and then we look at strengths and weaknesses of an organization. We leverage the strengths, and we identify barriers and work on them. And look at right in the middle, development of EBP mentors. This is where we teach people how to do EBP. Because what do we know about mentors? They are critical. Mentors change people's beliefs, and beliefs drive implementation. Beliefs have to happen in two ways. One, I believe EBP is important. Two, I believe we can do EBP here. It's realistic. It's possible. So believing it's important, we've made great strides in that, just sort of in general. People really do think EBP is the right thing to do. Where most places fail now is, I believe we can do it here, because they haven't done the things we're talking about. They haven't developed those mentors. They haven't put in the infrastructure. They haven't created the culture. But when you get that belief thing going, people do evidence-based practice. It's not hard to want to do the right thing if you make it possible for people. So you can see from these blue boxes that clinicians' beliefs about EBP, they value it and they believe it's possible, and when that happens, implementation happens. We've done 9 randomized control trials of this model in different organizations, and we have shown that when you have beliefs go up, implementation goes up. And when you implement EBP, guess what else happens? You start to see those improvements in outcomes and ultimately decrease hospital costs. But look at the top green box here. Look what else we get. Not just the patient outcomes improve, but look at some of these other things that we get when EBP happens. Satisfaction, teamwork, cohesion, intent to stay from the people that you want to stay, and turnover goes down. So these are all the things that happen in an EBP place. And so that is super driven by having these mentors in place that facilitate beliefs and implementation. And so this is an organizational model that we have tested. So it's an evidence-based practice model. And when you use this as your framework with these EBP mentors as the core thing that you have to develop, we have seen tremendous outcomes. So developing these EBP mentors is critical. How do you do that? You got to teach people what it is. You have to learn it, because most people didn't learn it in school. We're doing a way better job of teaching it in school now, but up until the last maybe 5 years, EBP wasn't even being taught. So if people didn't learn it before, you got to get some education going. This is what I talked about, beliefs. Just said this. There's 2 types, and so you've really got to focus on beliefs, because when beliefs go up, EBP implementation goes up. So let's talk quickly about barriers. Always number one, we don't have time. We don't have time to do this on top of everything else. Well, here's the thing. I'm not asking you to do it on top of everything else. I'm asking you to do it as you do everything. So it's how you present the time problem and how you're going to address the time problem that matters. So here's who's telling you how busy they are. ICU nurses are busy. This is a great study where they looked at ICU nurses and how busy they were. Look at these numbers. Nurse activities per hour, 125, and they switch between activities every 29 seconds. That's busy. But so who are you going to say, you're going to throw this burden of looking up the literature and doing all, you're going to throw it on top of your ICU, staff nurses? Probably not the best place to throw this and say, you guys need to go out and do this. You've got to create these structures where you have these EBP mentors who help these frontline people do this because people are busy. But being busy doesn't negate having to find a way to get the right thing done. So what you really have to start looking at is what are we spending our time doing? Where is all this time going? And I will tell you the greatest loss of time in hospitals, and from my perspective, is meetings. If you want to go find time, go look at how many meetings are going on in your organization where this is what they do. And I sat through these for 30 years of my life. Brainstorming meetings, right? How's that working? Here's what brainstorming can do for you in solving a problem. You never solve anything because you just keep trying somebody's idea 1 month after another, and then another month, and another month. And what if the idea is a bad idea? You just implemented a bad idea, and then next month you can implement another bad idea, but you never solve the problem. So this is not an evidence-based approach to problem solving. This is old ways of doing things, and this goes on in meetings, in every meeting room in your hospital all day long. So what I suggest is an evidence-based approach to a meeting, which is you have a problem, you look at the evidence. Not at the meeting, you find out what the problem is, and you say, I will go look at the literature, meeting adjourned, and then you have a meeting 2 weeks later, and you present the evidence and say, here's what we're going to do. We're not going to have a brainstorming meeting. We're not going to pick Mary's fun idea. We're going to go look at the literature. I will tell you, bring the synthesis back. Here's the best practice. This is what we're going to do. So you have a 10-minute meeting to find out what the problem is, and then you have a 10-minute meeting to hear what the answer is. So you see how much time we're starting to save now? That's the time that somebody's using to go look at the literature rather than sitting around in a room. So my point is, where will we find the time? It's always been here. Here it is. Here's where the time is being frittered away. So on a different day, in a quiet moment, I want you to think about this. Think about how many how many meeting rooms do you have in your hospital? And multiply that times 8, because 8 hours a day, all those meeting rooms are having meetings in them. Then I want you to multiply that times how many people are sitting at those meetings. And I want you to calculate how many hours of meeting time are spent cycling around, brainstorming, and thinking about ideas we could try. And when you come up with that number, sometimes it's like a couple 100,000 hours a year. And then calculate the amount of money that's being spent by all those salaries in those rooms. And I say to you, take 10% of those hours and say that's how much time we want to work on EBP and looking at the literature. Just give us 10%, all right, and see what you can do with that. But this sitting around in office, in meetings, is really, really the way we've always done it. It's a completely inadequate and ineffective way to solve anything effectively, and it's not ever going to get an evidence-based approach to care to ever happen because nobody's looking at the evidence in these meetings. They're just hashing it around and brainstorming. So you've got to reframe this time problem because this is always the number one barrier. So when you don't say to people, I want you to do EBP on top of everything else. You have to say, an evidence-based approach to care and decision-making is what we're going to do all the time. It's not on top. It's just different than the way we've done it in the past. I already talked to you about this. Where do EBP and research and quality fit together? They're like Venn diagrams. They overlap in certain places, but they are very different. And this is the EBP funnel. Every question goes through the EBP process first. If what comes out the bottom is sufficient evidence, implement the practice change. If what comes out the bottom is there's not enough evidence, implement a research project, okay? So, I got to see what time it is. Okay, I got a few more minutes. So, how do we get this done in the real world? Okay, so I'm going to go back to this. Oh, wait, let me go backwards. Hold on a second. So, this is currently what I think nursing sort of looks like. You know, everybody's on the phone. We got stacks of paper. Everybody's on the computer. Everybody's haggard looking. And I don't think most nurses ever had this in mind, nor do I think most of any other discipline had in mind, and quite a bit of fighting with each other also. I think this is what nurses and other clinicians have in mind. This is what we signed up for. So what do we have to do to get back to this being what we're doing all day, right? And so what do individual clinicians need to do, right? Everybody's got to get on the EBP bandwagon at some level. You can't just let people off the hook and say, all right, 6 of us are going to be the EBP champs on this unit, and the rest of you can do what you've always done. Forget it. It won't work. It is all, everybody, it's all in. It's all in. And so the people who are your negative people, your laggards, whatever you want to call them, the OJRs, on-the-job retired people, people who haven't done anything that everybody else is doing for the last 10 years and they have no intention to, those people have to be addressed, because if you have an evidence-based practice in place, 95% of the time it has to be delivered, or it doesn't get the patient the outcome. So if you have 5% or more of your entire staff not delivering that evidence-based interaction, you might as well not have anybody doing it. You've got, it's all in. So everybody's got to get on board in some way or another. And so my tool for you for that is we conducted a study here at our center and developed the EBP competencies. We did a Delphi study, not going to get into the details, scientific study, and we developed the evidence-based practice competencies for practicing registered nurses and advanced practice nurses. These competencies were tested in nursing but have been utilized across multiple disciplines in multiple places. And basically, these are 13 competencies for anybody touching a patient from a nursing perspective in our organization. Everybody. I don't care if you have an associate's degree from 1963. If you're touching a patient in this organization, these are the competencies relative to EBP that you need to own and be able to do. And competencies include knowledge, skill, and attitude. And then there's another 11 for your advanced practice nurses. And you can just, these are published, you can just take them and start embedding them. Put them in your job descriptions. Put them in your performance appraisals. Put them in your clinical ladders. Put them in your journal clubs. Just start to insert these competencies because they're measurable, they're tested, they're realistic, and there's no argument. You're not all trying to figure out, well, what should we be able to do? This is what you need to be able to do. If anybody wants more information about them, you can contact me because you'll have my contact information at the end of this presentation. I will help you utilize these. They're a fabulous tool for building EBP in an organization. Leaders, got to get engaged. They are critical to an EBP culture. And the leaders have to do what only they can do. They don't have to be out on the floors encouraging people to do EBP. Leave that to your EBP mentors. Leaders have to be leading EBP at the C-suite level, way up in the organization, creating the environment. There are certain things about an evidence-based culture that only high-level leadership can do. That's what they've got to do. So they got to do what they got to do, and that means create the environment. Okay? This is what an EBP environment includes: support, encouragement, voice to the clinicians, negotiating those barriers, getting people educated, being a role model, calling to this common purpose and this continuous commitment to doing the best thing for our patients and keeping the momentum going, because you can get this thing going and man, it can really get pounded down by those negatoids. So you got to have champs out there fighting for EBP to get going and stay intact. All right? You got to make an investment in it. Personal, financial, got to have that return on investment, you know? And so there does have to be, and most of this investment is in some infrastructure and EBP education, quite frankly. That's what it takes. You've got to develop those mentors, okay? So this is a big change in an organization. We know a lot about change and how hard it is, so I'm not going to read you this slide, but just know a big change is a big deal. And just know that not everybody likes change. So these laggards up here, 16 out of 100 people, almost 2 out of 10 are laggards. They're not coming no matter what you do. So don't spend your time trying to drag these people along. Get these people down in the early adopters. Get them fired up. Go find your first followers and get them engaged and build them up and support them. And eventually the culture shifts when you get enough early adopters and begin to get this middle group. That's when the culture changes and this late majority comes on. And these laggards are just never coming, so don't spend a lot of time on them. Role modeling is critically important. I'm not going to have a lot of time to talk about these slides because they're just kind of fun about culture, but I'm running out of time. So just know that passive provision of resources is not enough. You've got to do a whole bunch of things. I've talked about all of these. So here's the little checklist for you. And here's what it takes: vision, leadership, belief, planning, and persistence. I want you to know that when you want to build an EBP place, don't talk about why you're going to do it. What you're going to do, talk about why it's important. Get people motivated. Get them excited. Help them understand that this is what we have to do for our patients. Leadership has to be engaged. You can't make this the manager's job on top of everything else. You've got to have an organizational transformation requires leadership. And that includes the manager, but it can't be just dumped on the manager, all right? We talked about beliefs. You got to have a strategic plan. You got to write SMART goals. That way they're measurable. And you've got to be incredibly persistent. You can never, never, never quit and never stop paying attention, because those laggards and negatoids, they will be working constantly to keep it the way it's always been because they love it that way. They built it that way. So you've got to be persistent. You plan for the barriers. I guarantee you're going to see them. One is skepticism, right? We know how to address it, right? But trust me, it's out there. People will bring up the past, the way we've always done it, and how awesome it's been and how wonderful. And the past is extremely powerful. These resistors we've talked about, the lack of a strategic plan is a huge barrier. A lack of resources. See, all these things I'm listing, there's a strategy for every one of them that we've tested, and we know we can break through these. Fatigue is a huge problem. People are tired, all right? So pace yourself. And subterfuge, which is people in your face saying, oh, yeah, it's a great idea, we're all on board, and then when you walk away, they do everything they can to undo whatever you're trying to do. So you know who these people are. You've got to have a plan for them. And so just as you know, these are all the things that are going to get in your way to get EBP going. These are the same barriers that pop up when you're trying to sustain it. So always be attentive to these same barriers, whether you're getting EBP going or whether you're trying to sustain it, okay? So don't try to boil the ocean, because you can't boil the ocean. I'm from New Jersey. I grew up at the shore. Can't boil the ocean, okay? But you've got to get some small pots of water cooking. This is not something that can happen without energy and passion and champions and persistence. You got to be General MacArthur. We are not retreating. We are moving forward in a different direction. You got to be ready for all those barriers and have a plan ready for whatever pushback you're going to get, because that's fine, we'll go over here. And then that's fine, we'll go over here. But you've got to get it going, and it can't just be one person. So start with low-hanging fruit. Don't tick off the most powerful group in the building with your first project. Start with some small wins. Start with things that are really easy to fix but that have a big impact. Start with the things, little things that are driving people crazy, and there's a ton of them. If you have a contest where you just have people write down the things that are making them go crazy every day, I guarantee you will have a basket full of little notes with crazy makers in a couple of days. There's so many things going on that people are like, why the heck do we do it this way? So pick your low-hanging fruit. Do not try to do this alone. There's lots of resources out there. Use the buddy system and have a plan and understand the power of this approach. When decisions are evidence-based and patient-centered, that's always the right answer. There will always be people that will say, I don't like that answer, or I don't want to do that. But when when you have the evidence in your pocket and you can present it to people with confidence, and you say, this is not what we want to do, this is what we must do. We know this is the right thing to do. The argument against that basically ends up being, but I don't want to. That's really hard. I don't want to do that. And when somebody says to you, I don't want to do the right thing, here's what I want you to be ready to say to them. Ready? I hear you, but this isn't about you. What I'm talking to you about is not about you. It's about the patients. We're here to do the right thing for the patients, and sometimes that's hard. But when we know what the right thing to do is, we must find a way to do it. And so that's the kind of conversation you're going to be able to have with people. It's not going to be emotional. It's not going to fight, I want to do this and you want to do that. Because you're out of the wanna category. You're in the what we must do category. So it is an extremely powerful position to be in. It changes whining to winning, and when it totally changes the power grid. The power becomes doing the right thing for patients because the evidence supports you and gives you strength and courage. And you don't get into these hierarchical power grids anymore. It's just, we're going to do the right thing for the patients, okay? So it takes courage. You can't discover new oceans unless you have the courage to lose sight of the shore behind you. And so you do have to take some risk, but it's well worth it. And so how do you know when you're there? Decisions are not hierarchical or power-based. They're evidence-based. And it takes a lot of the emotional and the stuff out of it and all the fighting and that sort of thing. So you don't really fight not so much fighting. It's more just, this is how we're going to approach care moving forward. So these are just a couple things. These are the things that are really hot in EBP right now. Evidence-based leadership is a big topic. Certainly transdisciplinary evidence-based practice. Evidence-based quality improvement. No QI project without the evidence to support it to begin with. So you can take all your lean stuff, but if you have a bad idea and you get really lean at it, you're just going to get lean at a bad idea. So evidence-based practice is how do you get the right idea, the good idea, the best idea. QI is how do you get really good at the good idea. So evidence-based QI is the only kind of process we should have. They should be married together. And translational research, and then just a little ad at the end for our new Helene Fold Institute that we're launching. We're going to have our first summit here in Columbus in October where we're going to launch our new summit and really get things going with EBP on a much bigger scale. We're going to have an amazing 3 days here in Columbus. So I'm inviting all of you to come to Columbus for our summit. And I think I'll end there because I'm pretty much out of time, other than just saying, kind of be reflective, see where you're at. What can you do? What more can you do? And what one incremental thing could you do to be more evidence-based tomorrow than you were today? And I always love to say at the end, I always try to be more like Albert Einstein because he's super smart. And his best quote is, the best thing to do is never stop questioning. So on that note, I'll end. I never leave room at the end for questions. I'm sorry, because I just could go on and on about EBP. But if you have any questions, you'll have my contact information, and I'd be happy to hear from any of you. Or if anybody's interested in the slides, you can get in touch with me, and I can provide them for you. Okay? All right. Thank you.
Thank you so much, Lynn. That was really, really great. This was such an important topic. Thank you for participating, and have a great day.